Laud and applaud their presence, and I'm sure their presence will add value to this conference. And with this, we come to the end of this session. Thank you. Thank you, sir.
Thank you, sir. I would like to speakers and chairpersons, please move for. Request our chairpersons, Dr. Vimal Nakra sir, Dr. Rajiv Gupta, Dr. Rajiv Lochan, and Dr. MPS Chawla to please come on the stage.
Dr. Rajiv Gupta is not here. I request Dr. Kher sir to kindly come to chair the session.
Dear friends, without wasting any time, I think we'll start with the next session of this evening. We have none else than Dr. S.T. Chhabra, who is known to all of us to speak on the subject. Subject is very wide, but I'm sure he'll be able to do justice to it. Subject is nephrology today and tomorrow. When we were students, it was today. Well, it is tomorrow. When we were there, the only thing was by kidney खराब होगी यार अब आयुर्वेद या homeopathy करा लो तो ठीक रहेगा नहीं sir. Now we have lots of things. No, but we have lots of things. So Dr. Chhabra is a graduate from Amritsar and his DM is from PGI Chandigarh. He, I think, was the first nephrologist in East Delhi. He worked as a professor for a short time, then he shifted to East Delhi, then started dialysis and nephrology in East Delhi, then he shifted to Max Patparganj. Now he's heading both Patparganj as well as Vaishali. And he looks after, he's more interested in teaching rather than working. He teaches DNB students. On to you, Dr. Chhabra.
Thank you, Dr. Lochan. The subject which I am going to speak is nephrology, past, present, and future. And my task has become extremely difficult without Dr. Vijay Kher sitting on the dais. Wouldn't be able to say any stories where he is not involved or I was not involved. So it's becoming very difficult and I'll be picked up for all my errors very easily. Anyway, the outline of this topic which I am going to speak is that how was the nephrology started? What was the history of dialysis, the vascular access, the history of renal transplantation, history of immunosuppression, then the start of nephrology in India, and since we all stay in East Delhi, the start of nephrology in East Delhi. The present day nephrology, that is how much is the dialysis and vascular, what kind of dialysis and vascular access is there today, what is the state of renal transplants today. The future of nephrology stands into the novel diagnostic methods, the novel therapeutic alternatives, and the various medications which are on the rise and have important role. Although there was knowledge about the kidneys being involved in certain diseases, nephrology as a branch is quite young. The world's first society of nephrology was the French Société de Pathologie Rénale, and its president was Jean Hamburger. The first meeting was held in February 1949. First meeting of the International Society of Nephrology was held at Evian in Geneva in 1960. So less than 60, 65 years old societies. The father of nephrology, John Putnam Merrill was known as the father of nephrology, but Richard Bright was born in 1789, was a British physician who was the first to describe the clinical manifestations of kidney disorder known as the Bright's disease. And the old Boyd still has Bright's disease as the glomerulonephritis described, and we went through that in our pathology lectures. John Putnam Merrill was an American physician and medical researcher, and he led the team which performed the world's first successful kidney transplant. He is generally credited as the father of nephrology or the founder of nephrology, which is a scientific study of the kidney and its diseases. The term dialysis was coined by Thomas Graham, the professor of chemistry in Glasgow in 1861, when he observed crystallized diffusing through a semi-permeable membrane that is a vegetable parchment coated with albumin. The first human treatment occurred in Germany, where George Haas performed 15 minutes of complication-free dialysis on a terminally ill uremic patient. Dr. William Kolff is considered as the father of dialysis. This young Dutch physician constructed the first artificial dialyzer, that is the artificial kidney, in 1943. In 1930s, when Kolff watched helplessly a young man dying slowly of kidney failure, he decided to find a way to make a machine that would do the work of the kidneys. World War II erupted, and that time, although the materials were scarce, Kolff improvised using sausage skins, orange juice cans, a washing machine, and other common items to make a device that could clear the blood of toxins. In 1943, he created a rudimentary rotating drum dialysis machine using cellulose tube that was wound around a wooden slat drum which dipped into the dialysate bath at the bottom of its turn. Rotation of the drum powered the movement of the blood as there was no blood pump. Dialysate was made by adding known quantities of salts to tap water, and ultrafiltration could be achieved by adding glucose to the bath, although this was unpredictable. During the course of the next 2 years, he treated 16 patients with acute kidney failure but had little success. All that changed in 1945 when a 67-year-old woman in uremic coma registered consciousness after 11 years of hemodialysis with Kolff dialyzer. He published his work in the seminal report, New Ways of Treating Uremia. Kolff's machine is considered the first modern drum dialyzer. In the late 1940s, Kolff came to the United States, where he continued his research. With dialysis on its way, next was the vascular success. Now the problem is you are devising a method to clean the blood, but the biggest problem was how to get the blood out and let the blood go in. Dr. Belding Scribner, a young professor of medicine at the University of Washington, came up with the idea of connecting the patient to the dialyzer using a plastic tubes. And if you look at this photograph, this is a primitive photograph of an arteriovenous shunt, where one tube is getting into the radial artery, another into the cephalic vein, and they are connected with a U-tube outside the body. The Scribner shunt, as it was called, was developed using the newly introduced material, that is Teflon. With the shunt, it was no longer necessary to make new incisions each time a patient underwent dialysis. In 1962, Scribner started the world's first outpatient dialysis facility. Pioneering work in renal xenotransplantation had been performed by Emmerich Ullmann in 1902 when he transplanted a kidney between 2 dogs which lasted for a number of days. Around this time, Alex Carroll was working on the methods of vascular anastomosis with the end-to-side Carroll patch still bearing his name. Russian surgeon Yuri Voronov performed the first human deceased donor kidney transplant in 1933. The ABO-incompatible allograft was implanted into the recipients of the leg, and the patient expired 2 days later. The first intra-abdominal kidney transplant for a patient of end-stage kidney disease, which was actually polycystic kidney disease, occurred in Chicago on 17th of June 1950. Richard Lawler performed his first and only kidney transplant on a 44-year-old Ruth Tucker. The ABO-compatible graft lasted 10 months, but the patient lived a further 5 years, apparently with her small residual renal function. The first living donor kidney transplant was performed by Jean Hamburger in Paris in 1952, but allograft failure occurred at 3 weeks. Now this photograph shows you the donor and recipient and the doctor explaining, John P. Merrill explaining the dialysis machine. The first successful live donor transplant was famously performed by Joseph P. Murray with the assistance of Merrill at Brigham in 1954. Ronald Herrick donated one of his kidneys to Richard Herrick, that is his identical twin, so it was easier since it was an identical twin, who was suffering from chronic nephrosis. Richard lived for 8 additional years. Then the problem was how to immunosuppress and let this transplant grow. Peter Medower and Frank Burnett won the 1960 Nobel Prize in Medicine for the work that they defined rejection, immune tolerance, and early attempts at immunosuppression. The whole body irradiation was sporadically used and then unsurprisingly abandoned due to poor tolerability. Cyclophosphamide, thiopurine, and high-dose steroids are used before azathioprine, and low-dose steroids are found to have the efficacy. In 1965, one-year allograft survival rates was over 60%, with living-related grafts even higher. Further advances in the 60s included the development of anti-lymphocyte preparations, Paul Tarasaki's seminal experiments leading to tissue typing and cross-matching known as Tarasaki plates, in which it was done. Cyclosporin was adopted in the 80s and led to further process reduction in the early rejection rates. Logistical and legislative changes throughout the world allowed the deceased kidney donation and facilitated kidney transplantation, becoming a mainstream therapeutic option for end-stage kidney disease. Now, I'll come to the history of nephrology in this country. And this is probably synonymous with the life story of Professor Kripal Singh Chugh, the mentor, the teacher, and the guide to many of us, including Professor Vijay Kher, myself, and many other nephrologists sitting in this hall and in this city as well. Professor Chugh, while he was doing his MD, was fascinated with the kidney diseases and wanted to do a thesis on the kidney, but nobody was accepting him to do that thesis. He forced his way. Later we came to know about his nature, and he always was like that he could force his way wherever he wanted, and finally made the Punjab University people agree to give him a thesis on kidney biopsy, and he was the first man in this country to have started the kidney biopsy. During his MD, he ended up reporting on 50 successful renal biopsies, and in 1958, his thesis is the first systemic study in the field of renal disease in India, and in 1961, it enabled him to become the first qualified nephrologist in this country. The first twin coil artificial kidney dialysis machine arrived in India in 1961, donated to Christian Medical College, Vellore, from the Christian Mission of USA. His Excellency Shri Gopeshwar Prasad Sahi, the erstwhile Maharaja of Hathwa in the old state of Bihar, was the first person to receive dialysis with that machine. The first dialysis treatment in North India was performed on July 3, 1963 at PGI at Chandigarh on a patient with acute renal failure. The dialysis bath was prepared. If you look at this photograph, this will show you the dialysis bath which is there lying at the bedside of the patient. By adding pre-weighted chemicals to the 100 liters tank, which contained warm tap water and was maintained at body temperature by a heater incorporated within. The twin coil required 2 units of blood for priming. Access to circulation was obtained with an arteriovenous cannula through a cut down in the radial artery or a femoral vein and another cannula in the radial vein. The cannula would be kept operative for only 1 or 2 dialysis treatments, and it did not take long to use all the excess sites. Now, finally, Dr. Chugh started dialyzing the patients with the keel dialyzer. Keel dialyzer, if you look at the patient side, is a long dialysis machine. It's not a machine, it's actually a dialyzer. It had parallel plates and there were membranes inserted in that, and it used to be prepared in the dialysis room of the PGI Chandigarh. The dialysate fluid was made and put into a drum on a height, and if you look at that drum on the height, this contains the dialysis fluid, and a tube was taken from there to run into the keel dialyzer there, and the patient was dialyzed. 1 year after hemodialysis therapy was introduced to India, the first peritoneal dialysis in the country was performed once again in PGI in 1964. At that time, the PD catheters were not available, and we devised the PD catheters by making holes into a tube, which was actually the twin coil dialyzer's tube, and we started introducing that catheter with a trocar and cannula into the patient's abdomen and dialyzed the patients with that. Sporadic attempts were made for the continuous ambulatory peritoneal dialysis in that era, but failed, though CAPD now is a very successful modality and is fairly commonly used in this city as well as in the other areas of this country. Now, this photograph is showing you something very interesting. On the right and the top is the kidney biopsy needle, which Professor Chugh used, and Dr. Vijay Kher and me have also used that to a good time. And now is the modern needle with which you are seeing. The difference is enormous and tremendous, and the procedure also has changed its site. The renal transplantation in this country, the first successful kidney transplantation in India was performed in 1971 at CMC by Drs. Mohan Rao and K.V. Johnny, both of them who had been trained at Adelaide, Australia. In 1972, Dr. Inder Dhawan performed a transplant at All India Institute of Medical Sciences. But later in 1974, Dr. Rajveer Singh Yadav and Professor K.S. Chugh started the renal transplantation in PGI Chandigarh. The first recipient was an 18-year-old man who lost his kidneys to a membranoproliferative glomerulonephritis. And this gentleman spent around 5 years after the transplant working in the same department as the laboratory assistant. As far as this city is concerned, East Delhi's first dialysis machine was established in 1992. Till the year 2000, there were hardly any dialysis centers in this area. In the last 2 decades, East Delhi's got more than 50 dialysis centers. That is how we have progressed. We started renal transplantations in 2007 in Max, Patparganj, but initial few years we couldn't do many transplants. Later we were able to do around 100 transplants, and then we again had a lull. And now once again, over the last 1 year, we are actively involved in the renal transplantation service. And our twin center, that is Max Vaishali, Max is actually far ahead as far as the renal transplantations are concerned in the numbers as well as in the skill. Now these are the machines which will show you the change from so-called dialyzer machines which we discussed and which we saw in the photographs. These are the modern machines. This is a modern dialyzer. There's a dialysis machine, there's a hemodiafiltration machine, and there's a CRRT machine, all 3 in the row. The vascular access today is used as a modern hemodialysis catheter. There can be a tunneled cath or a permacath, and the arteriovenous fistulas, AV grafts. We have a stalwart among us by the name of Dr. Sanjeev Jasuja, who's a master in doing these catheterizations and AV fistulas. Once he's there, you'll be able to learn more from him. Easier to do transplants now with the numbers increasing progressively. 1-year graft survival rates are more than 95%, and 5-year graft survival rates are more than 85% according to many studies. A host of immunosuppressive agents, including rituximab, basiliximab, ATG, mycophenolate, tacrolimus, sirolimus, are available now to protect the transplanted kidney. Better antibiotics for the prophylaxis and management of peri post-transplant infections and better diagnostic modalities for the rejection are available now. Now we'll come to a little while for this fact is that what are the current CKD managements. There has been a tremendous amount of advancement now over the past few years occurring in this field as well. We've got host of drugs which have come up to retard the progression of renal failure. More important ones out of them are ACIs and ARBs, MRAs including finerenone or Levelsa, SGLT2 inhibitors, alpha-keto analogs, phosphate binders, and ESCs. Now, what is the future for us? Where are we? We have said we've got good dialysis machines now, we've got transplantations, but we are still not where we were, because what we're treating is nearly the end-stage renal failure. But what our aim is to see that the patient does not reach the end-stage renal failure. The blind spot for CKD diagnosis. The biggest problem which we have is that we come to know about the CKD after a major chunk of the kidney has already been involved or has already died or already not working. So the blind spot for CKD diagnosis, that is the reliance on the current EGFR threshold to diagnose the CKD, means that by the time the CKD is diagnosed, over 50% of the functional kidney mass has been lost, and the combined risk of CKD progression and premature death is already increased by around 2 to 7-fold. So what we really need at the moment is to have some kind of diagnostic modalities where we can start diagnosing the patients in the very early stage of renal disease, and at the same time, not only after the start of the early disease, we can capture the population which is at risk to develop the kidney disease and try and stop that, or at least slow down the progress of those kidney diseases so that we can have a better life and a better survival. Now this is a very busy slide. This shows you the new methods of diagnosis which are coming up. Some of them are already been approved by the FDA, some are in the pipelines. But once all these come up in this, we'll have a good armamentarian with us to diagnose this. Now what do we have? We have modalities now to assess the number of nephrons, how many nephrons are present in the body, how many not. Low number related is related to the kidney disease. Early detection of chronic kidney disease, the better assessment of acute kidney injury, improves the organ evaluation and organ donor evaluation. Like if you are able to assess the number of nephrons in the donor, you are sure whether you should be able to take that kidney for donation or not. The production of risk in drug-induced nephrotoxicity, and it allows to develop the strategies doing the dosing of the drug and the toxicity of the drugs. Now, what are the modalities which are used to assess the number of nephrons? These are some of the MRIs and PET scans. The iron oxide ferritin is bound to the GBM, that is glomerular basement membrane, and can be detected by the MRI and thus lead to the detection of the number of glomeruli present in the kidney. Similarly, the radio CT PET scan, that is the iron oxide which is radio labeled and that is used in the PET scan, can give you the number of nephrons and the number of glomeruli in that. Sodium MRI is another developing line. There's a flow of sodium from the cortex to the medulla to the pelvis, and that is assessed by the sodium MRIs which can be done or which are being done experimentally as yet, not very common. Then of course the functional MRIs, that is allows to measure the kidney volumes and blood flow in the renal arteries, renal water content and the tissue oxygenation. Out of them is one is bold MRI, that is blood oxygenation dependent MRI, which measures how much oxygen consumption is happening at various areas of the kidney. The DW MRI and the HP13C MRI are the non-invasive assessments of oxidative stresses in mitochondrial pyruvate dehydrogenase activity after renal ischemia reperfusion injury. Once these modalities are available, you will be able to catch hold of the patients in a much early stage and would be able also to know the pathogenesis of the disease as well. Then what we have is the methods to assess the fibrosis. If how much fibrosis the kidney has got, and that we have certain biomarkers, CNA35 CT and ESMA-based MRI, two techniques by which we will be able to assess the fibrosis occurring in the kidney. Contrast-induced enhanced ultrasound is becoming more and more important because it's a totally non-invasive technique and will be able to give us a very good information about the renal functions. Then proteomics and metabolics, again, some of the markers, that is CKD273, a marker of chronic kidney disease, THSD7A, the primary membranous nephropathy marker, NANA-D metabolites, which are seen in the AKI risk population, FAT1 in the membranous nephropathy again, and anti-nephrin antibodies seen in the minimal change disease. And there are few more in the pipeline as well. These are the markers which will be able to give us the idea about the presence of a disease much earlier than we can diagnose it with our present methods. Similarly, there are other biomarkers which are going to be available, which will be giving us the insight about the renal damage in the chronic kidney disease as well as in the acute kidney disease. These can be PCX, KIM1, TNF-alpha, A2HPDI, and AKI biomarkers, DKI biomarkers. They all will be in due course of time available to us. The last is the cell-free DNA, which is also available at the present moment also, which is used for the diagnosis of rejection and some of the other kidney problems, which will help us to find this disease out. After this, we'll come to that what are the newer therapeutic techniques which we are expecting or which we are wanting to develop and which we are going to have in due course of time. The most common, which you must have listened a lot of, is a wearable artificial kidney. This is a dialysis device which will allow the patient the mobility and get dialysis while performing their day-to-day work. That is a small machine which will be embedded or which will be attached to the patient itself. Patient can move around, do his work, and the dialysis can be carried out at the same time. Xenotransplantation, that is another field which is becoming very transparent, very important, and all of you must have read in the newspapers as well that a pig kidney was recently transplanted in the human being and stayed there for some time actively. This is a future of the kidney transplant, and if we are successful in doing that and we break the codes of that, probably we'll be on a much, much better and a much stronger footing. Stem cell based therapies have been used for quite some time with the disputable results. Some people show that there have been good results in this and rely in the kidney revival and the kidney tissue revival in that. Bioengineering bioartificial kidneys, that is a renal assist device. This is an interesting phenomenon. In this, there are two things which are combined together. That is one part which filters the blood for the uremic toxins and the toxins, other toxins, and the other part which works as a kidney and does as the endocrine or hormonal function of the kidney as well. Similarly, implantable bioartificial kidney also has a similar kind of a structure. These two are in the experimental stages, and if successful, once again will change the scenario of the treatment of chronic kidney disease. Then a glomerulus or a tubule on a chip. That's of course the latest thing, that you have grown the renal tissue on a chip and inserted into the body, which will give you all the functions of the kidney available to itself. Now, there are the common medications which are available now, which are on the rise to treat this. The more common is the non-steroidal MRAs, that is the mineralocorticoid receptor antagonist. Out of them is finerenone, which has got a beneficial effect on proteinuria and CKD progression. Aprenolone is there undergoing clinical results. Aldosterone synthase inhibitors, once again, is the inhibitor of aldosterone synthase enzyme, or CYP112B2. These all will be helpful in reducing the proteinuria and retarding the progression of renal disease. Endothelin receptor antagonist, that is ERAS, sparsentan, it's a dual endothelin angiotensin receptor antagonist. It's available in February 2023. It received the accelerated approval by the USA FDA for treating IgA nephropathy. Main concern for ERA is a sodium retention. It may be hypothesized that co-administration with SGLT2 inhibitors may improve the safety profile. HIF stabilizers, voclosporin are the other drugs which are there. Thank you very much. The future for the kidney disease is very exciting.
Thank you, Dr. Kher. Wonderful talk. A very nostalgic journey. Sorry, Dr. Kher. Oh, Dr. Chhabra.
One and the same thing, don't worry.
Very nostalgic journey from zero to today. And yes, I think days are not far ahead when there will be kidney selling person sitting outside. Ye wali kidney lagwa lo. And I don't know, Dr. Kher is the next speaker. I should ask him for his comments, or should we wait for his talk? Give a few comments.
I think Satish has been with me. He's just 1 year junior to me, and we have progressed from Amritsar Medical College to PGI Chandigarh, and then he was for some time in Ludhiana and then moved to Delhi, and I also moved to Delhi. So we've been sort of seeing the scenario of nephrology evolve over these 45, 50 years in this country, and fortunate to have been Dr. Chuk's students, and the progression of nephrology has been, he's been excellent in giving you the overall perspective. The only thing I would say is that how can we improve current practice of nephrology right now? There are a lot of new things which will come, but whenever they come, they will come. But till that period of time, what is it that I can do in my practice to improve? So the important thing which he highlighted is that identify people at high risk of kidney disease, even before they develop kidney disease. And physicians are the best people because patients are with you before they come to the nephrologist. So I think for physicians it's very, very important to identify people who are at high risk. And who are the people at high risk? He's already highlighted. People who have diabetes, family history of diabetic kidney disease. So somebody who's already had a family history of that diabetic is very likely to develop kidney disease. Can you do it 20 years before? Yes, you can do it. With all the new drugs that are available now, you can SGLT2, mineralocorticoid, antagonists, AS and ARBs. Unfortunately, AS and ARBs are not used by physicians for the fear of rise of creatinines and all that. And you use nonsense drugs like keto analogs, prebiotics, probiotics, which don't have any. He hasn't mentioned their name. He didn't put it in the list of drugs. But every nephrologist, every physician is using these drugs. But these drugs are not used. And you are increasing the burden of pill burden. Huge pill burden. And what is the patient going to eat? He is going to continue these keto analogs because he feels this is the kidney drug. He will discontinue antihypertensives in many other drugs and will continue keto analogs which don't have any significant role. These are low-hanging fruits, very easy for physicians to use to say that these are the kidney drugs. Whereas you should say SGLT2 is a kidney drug. ACE and ARBs are kidney drugs. Mineralocorticoids is a kidney drug. So these are the drugs which I would suggest you should be using more often in your practice in early stages of kidney disease. That is what will improve the quality of care till we get what he has said the future might hold, and I hope to live till that period of time to see some of these progresses, but we've had tremendous progress ever since I was a student. Thank you, Satish, for enlivening us through all this history, and I know he and I at night would make these dialyzers, the keel dialyzers with the nurses for 4 or 5 hours at night. We would not sleep on the night duties and would make these. Dialysis was 16 hours those days, not 4 to 6 hours, 16 hours. And invariably these would leak also.
Dialysis used to start at 6 a.m. in the morning, finish at 8 p.m. at night.
4 o'clock in the morning.
Machines were, after the machines came, it used to take 2 hours minimum to put that bloody machine into the functioning order. Conductivity won't come. So won't come. What can you do?
JP Narayan was the most famous person who was to be dialyzed in Delhi. And Irvin Hospital, I was registered there. Our department, we were Dr. P.D. Gulati and Dr. S.N. Rizvi. So a dialyzer was brought to us. It was huge. The whole room was occupied by us. And we and our technician, whole night we used to prepare some solution, which I don't remember today, and then go for dialysis. Eventually he shifted to Jaslok from Delhi, and where dialysis was carried out. That's how I remember about dialysis. And if there are no comments, very nice talk, sir. And what I propose today is, because East Delhi, he was the first nephrologist, still the most active, let us name him the father of nephrology in East Delhi. Do you agree? So Dr. S.C. Chhabra, father of nephrology of East Delhi.
I'm humbled.
So our pleasure, our honor.
I would request the speakers and the chairpersons to move to the felicitation, and I would like to request Dr. Vijay Arora to please facilitate our speaker and the chairpersons.